My name is Dr. Brittani Seynnaeve, and I'm so excited to be here with you virtually today to talk about an important topic in pediatric melanoma, and that is the impact of clinical research. I'm a pediatric oncologist in Pittsburgh at the University of Pittsburgh Medical Center and Children's Hospital of Pittsburgh, and I specialize in the care of patients with melanoma and in clinical research regarding those patients with melanoma. So we'll get started here. Our outline for this talk will be to define clinical research, so we have a background in that, to think a little bit about research databases as a tool for clinical research, talk about the uses of a research database, what it takes to build a database, what the effects are, where we are with a pediatric melanoma database, and where we can go in the future. So first, what is clinical research? Clinical research is any patient-oriented research. So research conducted with human subjects or on material of human origin, such as pathology tissues or specimens from biopsies. In our patients, of course, that's the biopsy from the original melanoma or melanocytic tumor. And this is for which an investigator directly interacts with human subjects. This can also be epidemiologic studies, understanding how frequently a certain disease or illness affects the population, and also outcomes research. So knowing how patients will do if they have a certain diagnosis in the long term, and being able to share that information with our present patients in real time. The one thing that I'm always asked as a researcher and as a physician who sees patients is this investigational? Is this experimental? Am I a guinea pig if I'm involved in research? And I would say for the vast majority, the answer is no. Most of our research is designed really truly to benefit the patient. And a lot of times research is not necessarily experimental, or it doesn't mean that we're doing something to you as a patient, but rather might be collecting information, which is what we will be talking about more here today. So what is a research database? Most patients who have been diagnosed with melanoma or other cancers will be asked to participate in some form of a research database, and understanding what that's for is so important to know how you can contribute to improving the management of all patients with that same diagnosis. So it's a file containing uniform information about individual persons collected in a systematic and comprehensive way in order to serve a scientific, clinical, or policy purpose. And it really is, it's an important clinical research tool. So the data are collected in a uniform manner for every single patient. What is data? It's anything pertaining to that patient, and what you collect would be defined by what you're trying to learn more about or study. So we'll get into a little bit more later, but data can be as simple as the age of a patient when they're diagnosed with a certain diagnosis. What is that diagnosis? Did they have any treatment? Did the melanoma ever come back? Or are they living X amount of years since their diagnosis without any return of melanoma? Or it can be as intricate and involved as collecting the original biopsy samples to look at under the microscope, and collecting all of the very, very specific information about that biopsy, and evaluating outcomes of patients based off of what their original tumor looked like under the microscope. And these are just examples. There's hundreds and thousands of different data elements that can be collected for any one particular research database for clinical research. So again, these data can be patient reported, or they can be from the medical chart collected by medical staff. And this is typically without any patient identifiers. Like I said, we are not usually collecting, a patient's own personal names, but rather identifying them as a boy or girl that was diagnosed with melanoma at 5 years of age, etc., for example. And a patient database can be a really powerful tool to observe the course of a disease and to understand variations in treatment and outcomes over time. And I think I mentioned this before, but the database really should be designed with respect to the intended purpose. So if our purpose for a pediatric melanoma database is to understand what the long-term outcomes are and what the features of the patient and the disease are at diagnosis that can correlate or potentially predict those outcomes, we would want to make sure that we are designing the database to collect all of those very specific variables before we would launch it and ask patients to contribute their data. So what are the different types of research databases? First is retrospective, and this is looking back. So looking at melanoma cases that have already occurred, and we already know the outcomes, and collecting all of the information that came prior to those known outcomes. There's pros and cons to this. The pros can be that we can interpret data quicker once the database is compiled. We don't have to necessarily wait years for the outcomes to occur. And overall, it's cheaper since we don't have to keep the database running for as many years as it takes to develop those outcomes. The cons are that the disease knowledge treatment advances may not be captured. So if we're looking back in time and seeing how young patients did with melanoma when they were treated in the early 2000s, that might not easily be able to be translated to today with all of the advances that we have with treatment options overall for melanoma. The other type of research database is prospective. So this is looking forward. Melanoma cases would be captured and collected as they occur, and we're waiting for the outcomes, meaning a new patient is diagnosed with melanoma, they enroll in our research study, which is a prospective database. We collect the information at diagnosis, and then every time we see the patient afterwards, we continue to collect information so that in 5 years we can tell a story for those type of patients. But again, we would be waiting to see what the outcomes were over time. So what are the uses of a research database? I've alluded to this somewhat, but just to go into some more detail, the purpose can be to document the natural history of the disease. So the disease characteristics, the management and patient outcomes, with or without treatment, and to be able to put together a story of how one patient might be able to do with their melanoma diagnosis based off of information from many patients compiled together in the past. And for rare diseases, which we'll talk a little bit more about, but pediatric melanoma is certainly classified as a rare disease. The purpose may also be to identify correlations between disease features and patient outcomes. And so, you know, I sometimes explain to patients whenever they're newly diagnosed and in the office with me and we're discussing the diagnosis, that you know, if they have a particular question, we usually try to back up our recommendations for the patient sitting in front of us with some form of scientific data that we have from prior studies. And a lot of time in the pediatric melanoma world, that's really from scientific studies like I'm outlining here. So, you know, we might refer to the fact that we've had database studies or collections of large numbers of patients evaluating certain molecular tests on the biopsy and finding out if any changes in that can correlate with an increased risk for more aggressive melanoma or with a more indolent and benign course. And so that information that we gather from these type of studies is so important to be able to care real time for the patients in front of us. And this really is truly an important need for patient care. So not just in the pediatric melanoma world, but in many other diseases. I bring up this slide here just to highlight that our National Cancer Institute, the NCI, has an initiative called the Childhood Cancer Data Initiative, or CCDI, and that is to prioritize clinical research data needs for therapeutic progress. So we need the data, we need to understand how these diseases work and what to be watching for in order to make any progress in with how we're going to treat them and how we are going to improve outcomes. This is also for creating meaningful data sets for clinical care and associated research progress, which is what I've described in the past couple of slides, and then developing tools and methods to extract knowledge from data. And so in the pediatric oncology world, there's a lot of focus on collaborative work like this, like I'm discussing here in pediatric melanoma. Pediatric melanoma is only one type of pediatric cancer, but overall pediatric cancer is relatively rare as compared to adult cancer, and working together and compiling data from multiple patients across multiple treatment locations and areas within the United States and the world is so important to be able to grasp the whole picture of the disease and be able to make meaningful discoveries that impact how we treat our future patients. So what does it take to build a database? Well, it's expensive to establish it and to maintain it. It requires the participation of many patients and healthcare providers working together as a team with a collective goal in mind. It requires very careful management by those involved, with attention to detail and attention to ensuring that we're keeping patient data safe and secure. And there's many checks and balances. All studies of this nature require what is called an institutional board review, IRB approval. And I'll talk a little bit more about this because it is something that patients and their parents and caregivers ask me a lot about. Whenever I ask a patient to participate in such a study, you know, how will you keep us safe? How will you keep my information safe? And there's a specific governing body that's meant to do that so that they can ensure that the investigator, so someone like myself, is making sure all of those checks and balances are in place in keeping our patients safe. So what is this? What is the IRB, or the Institutional Review Board? It can be known as a couple other acronyms: Independent Ethics Committee, an Ethical Review Board, or a Research Ethics Board. And it's a committee used in research in the United States that's been formally designated to approve, monitor, and review biomedical and behavioral research involving humans. And so this is a lengthy process. It takes a lot of time, sometimes months, even up to a year. If you have a new study, even if it's a database study and you're not delivering any sort of treatment to the patient, there's still a lot of care that's undertaken by these committees to make sure that we're doing right by patients before we're even able to begin the research or collect any information. So changing gears a little bit, and let's put this all into perspective. We'll talk a little bit about epidemiology, or the frequency of pediatric and adolescent and young adult melanoma. I give a big title because as a pediatric oncologist, I often see patients from birth until up to about age 25, and in our oncology world, we often categorize the late teens and early adults as adolescent and young adult, which we sometimes abbreviate as AYA. Estimated new cases of melanoma for all patients of all ages in 2021 was 106,000 and some change. Looking at how many of these new melanoma cases occurred by age group, you can see that for the young patients 0 to 20 years of age, the ages of all of you at the time of diagnosis, that makes up a very, very, very tiny amount, so 0.4% or 420 cases a year. When we get into the older bracket of the young adults, the 20 to 34-year-olds, becomes more and more common, almost 5%, or about 5,000 new cases per year. And just to put it in perspective, for all new cases of cancer of all types in young patients in 2021, for our children ages 0 to 14 years of age, all cancers, skin cancer, brain cancer, blood cancer, there's 10,500 cases. And for that AYA population, 15 to 39 years of age, overall 88,260 cases. So overall, for all patients, 39 years of age and younger, there are less new cases of cancer overall than there are new diagnoses of melanoma in all ages in the United States in any given year. And so I always discuss this because it has for many years to many people, certainly not all of you in this in the room listening to this, and certainly not to myself taking care of these patients on a daily basis, but it's often seen like a drop in the bucket. And so in past years, the study of pediatric melanoma was not specifically focused on as much as adult melanoma. But that doesn't mean that it's not important, and that it doesn't need to be a focus. But we're working to catch up some of the time that we've lost in making advances about this disease. And I just showed you it's a drop in the bucket in terms of all melanoma, but when you think about children and you think about skin cancer, it's the most common skin cancer. We can't say that for older adults, despite melanoma being the most dangerous type of skin cancer in all adults, it's certainly not the most common. But in kids, it's the most common type of skin cancer, and I think that's a really important thing to keep in mind. This needs to be studied. We study all cancers regardless of how rare they are, when we have the one organ being our skin, we need to study the cancer that involves that organ. So a little more background for why does a pediatric melanoma database need to exist? So I just mentioned that cutaneous melanoma is the deadliest of all skin cancer. It's linked to nearly 75% of all skin cancer related deaths overall. However, there's a much lower frequency that we just discussed of pediatric melanoma, and often an atypical presentation of childhood and adolescent melanoma. And this leads to a lot of uncertainty regarding the diagnosis and the treatment and the outcomes amongst medical care providers, and ultimately that leads to suboptimal outcomes for our patients. And so we know there's been a trend towards less aggressive management of pediatric melanoma. And a lot of times I'll hear from people who come to see me for a new diagnosis of melanoma that they had been seen somewhere else, and they were told melanoma in a child is quote, not that bad, and not like adult melanoma. And I never know exactly what to make of that comment. We want to make sure we're taking care of any patient in front of us, and using scientific data to make those decisions. But that being said, we don't know what those specific features are to predict which cases are more or less likely to have their disease come back or have disease progression or death due to melanoma. It's not clearly defined, and this is really something that is important for us to learn about and to define, and we can do that through the use of patient databases. And one last thing I like to mention for anytime I'm talking about pediatric melanoma, a lot of I usually will get a question that so much advancement has been made over the past decade or two in melanoma in general, and can't we just apply that to children? Well, a lot of times we can, and we do. We never want to discredit all of the wonderful work that's been done so far that mainly has been done in the adult population. We use that data a lot to inform how we treat our young patients. But that being said, children are not just little adults. We know diseases manifest differently, and we know that's the case in pediatric melanoma. Children are growing and developing, and there's a lot of change that happens over time that can impact any disease, including melanoma. Their bodies work different, meaning there's different physiology. They might, process medications differently. Their bodies respond differently to different treatments. They're dependent on others for their care. They rely on a caregiver bringing them to an appointment to see a doctor to recognize that abnormal skin lesion. They're certainly, especially our young population, they're not independent to do those things on their own. And really importantly, they have a really long life expectancy. So we want to ensure that any child that we're meeting has the potential to have that long life expectancy that any other child without melanoma would also have. So with all of that being said, we've identified that there is a need for a pediatric melanoma database. We know standard recommendations for the management of childhood melanoma are needed, and we know we need large cohorts of organized patient data to serve as the groundwork to make these recommendations. So what were our goals many years ago when we were thinking about this important problem? Was to assemble a current multi-institutional database to better define this disease of pediatric melanoma. Multi-institutional means from many hospitals across the country or even across the world. We knew that we wanted to include some linked pathology information that's been digitized, or pictures taken of that original biopsy whenever pathology had been archived, for pathologists to review the original diagnosis now in the present time. As we know, and I know you'll learn more about this through different talks during this summit, the importance of pathology in pediatric melanoma. And then to thoroughly describe the population of melanoma patients to identify those prognostic or predictive factors affecting survival in patients 0 to 25 years of age. And all of this is to improve our ability to provide information to patients and families about the prognosis, and to tailor their treatment for their melanoma or their therapy according to that known prognosis. So how do we do this? What are the methods? We here in Pittsburgh have created a retrospective database. It's called a REDCap database with extensive diagnostic, clinical course, and long-term outcome data. REDCap is a secure web application for building and managing online surveys and databases. It's widely used by many, widely used in the healthcare setting. And then we created a linked digitized pathology archives of specimens whenever the pathology samples were still available to us. So what has our progress been? Well, when we initially thought of this idea many years ago, or several years ago, we established collaboration with 8 large melanoma treatment sites. Many of those are represented during the summit with our different speakers. Those participating institutions and our institution here in Pittsburgh have contributed more than 280 fully detailed cases. The last time I presented this topic was for the summit in 2019, and at that time we were still actively collecting cases, but at this point in 2022, all of our case acquisition has been completed. And thanks to the generosity of the MRF, I've had funding secured for being able to have analysis of that database and all of the exciting data that we've collected, and also to create a prospective database, which we hope to launch later this year, giving opportunity to patients and their families to participate in this in similar research real time in the modern era of pediatric melanoma treatment, and to contribute significantly to our progress in the field. And through this, we've really learned the absolute critical importance of interinstitutional or inter-doctor, inter-care provider collaboration in the assessment of rare diseases. So, you know, it really, for me, and I know for my colleagues, it's never about seeing more patients or you know, getting to see the one patient over another team seeing more patients. It's really about working together as a whole for a common goal to improve the outcomes of our patients. And it's impossible to do that without collaborating and working together. And so what kind of data have we collected? Demographic data, so age of diagnosis, sex, different information just pertaining to that individual person, pathology and molecular data. So what did the original biopsy look like? What testing was done on the original biopsy? Diagnostic evolution, that's a fancy way of saying how did the assessment of the original biopsy change over time? In pediatric melanoma, we know that's a huge hurdle for us to overcome. One pathologist might look at something and think that it's benign or not cancerous. Another pathologist might look at the exact same sample and think that indeed it does represent cancer, in this case melanoma. And so understanding how that evolves over time to us is important to know how we can improve the process and improve the accuracy of our diagnosis. In addition, we collected surgical data, the type of surgeries that were done for the melanoma, regarding the wide local excisions or the repeat surgeries, as well as whether or not there was lymph node surgery performed, what the staging was. So was it localized to that spot on the skin? How did it spread to the lymph nodes? How did it spread anywhere else? What was the clinical course and the outcomes? Did the patient go on to be alive and well? And you know, living now healthy without any evidence of melanoma, or did their melanoma come back? And what happened if it came back? And then lastly, the digital pathology image for a pathologist to go back in time and validate that original diagnosis. So how long has this taken? A really long time. And that's par for the course. So these efforts began in 2015, they continue today. It took over a year to establish contact with all of the sites and obtain IRB approval for all participating sites, which I talked about earlier in this presentation. It took over a year for sites to even identify their cases, figure out which cases they had seen over the past 20 years. It took over 2 years for those sites to go through and collect the data from each cases. This sometimes seems crazy when I tell people that, but when I get to the nitty-gritty of what it takes to build one of these databases, we'll see how many hours it can take to just collect data for even one patient, and then many more. steps and hurdles that it takes to work through to build a database. So isn't being interested enough? Sadly, no. I wish it was. I would love to do this day in and day out, but that's not all it takes. So collecting data from one patient's chart treated over several years can take 20 hours. That's for one patient. You have to have the personnel and the salary funds to be able to support this and maintain it over many years. So we're so grateful for our excellent research staff that we have that helps us with these, with that data collection. But of course, to work, one would need to be paid, and there has to be funds to be able to do that. And then, you know, importantly, researchers such as myself and sitting down, interpreting the data, sharing the results, not necessarily paid to do this. That's not a bad thing. But it does take time away from seeing patients who right there in the present time just need to be seen. And of course, that always takes precedent. And then a statistician is another personnel that's needed to help interpret the results. And then really the right questions need to be asked. You need to know a lot about the disease that you're studying to be able to build a database or build any clinical research project that you might think of. But it really is so important. So the approach, how we think about pediatric melanoma, how we think about treating a patient with pediatric melanoma, or any other atypical melanocytic tumor that may or may not be melanoma or skin cancer, really relies on data collection efforts so that we can formulate some care guidelines and optimal management and outcomes for these patients. So, you know, thinking of a couple of examples, why is this so important? You know, I often will refer to the concept of pattern recognition. Young kids in school will learn to recognize patterns and know when something is out of order and a pattern, and it's pretty similar to what we do here. I mean, you know, you always wish you have a crystal ball to be able to predict and tell a patient sitting in front of you, this melanoma is never going to come back. We don't need to give you therapy. We don't need to do surgery. But unfortunately, that's not the case, and that's not the real world, and that's not how it works. And so, without that crystal ball, we need this information. We need to say, okay, from prior research that we've done, you sitting here in front of me look most similar to this cohort of patients that we studied over the past 10 years, and those patients ended up having poor outcomes and having their melanoma come back unless they were treated with therapy up front, or vice versa. These patients did just fine. Maybe we can pull back and not do such aggressive surgeries and systemic treatment for you in this case. And so that's really how we utilize that data. And so, you know, I'm always struck by the cases where we wish we had that crystal ball. We know hindsight is 20/20. You know, and we want to identify those patients that'll have a poor outcome. Here's a patient that we saw at our center. She was a teenager. She was diagnosed with, in the original reports, was described as an atypical melanocytic tumor. She had a minor surgery and went on to live her life. She came back in a couple of years later, and at that time had melanoma all throughout her body, diagnosed with metastatic melanoma. And it was clear with our retrospectoscope that that original tumor was in fact melanoma, and it was going to be a bad actor, but it wasn't recognized at the time. And so these are the type of cases we want to be able to know more about from the time they walk in our door to prevent these outcomes for any individual patient. These are some of her medical images, you know, with permission to share. Of the first image is a picture, a CT scan of her lungs taken that shows all of the white shown there is all melanoma tumors in her lungs. The middle image that's black is a picture of a liver with a tumor in it, and then the last one is an up close of one of her biopsies that was done showing her melanoma. And, other examples, real life, an 8-year-old female, she comes in for a second opinion following a biopsy of a skin lesion. She's young, they weren't expecting this. They were told it was a wart, had it removed, and then got this shocking news that it was actually a melanocytic tumor or melanoma. The first doctor they saw said it looked like a melanoma, but they changed the diagnosis because, quote, kids don't usually get melanoma. The second doctor uses those results from prior studies using pediatric melanoma databases to show that 8-year-olds do in fact get melanoma, and her type of melanoma is at risk for spreading, and that changes the treatment for that patient sitting in front of us. And then the second doctor can also educate the first doctor by sharing the data and collectively working together for better care of the next patient that doctor sees with melanoma. And then there's a potential for a much broader use. This really can be the foundation for new treatment options for children with melanoma. It breaks my heart when I know that a kid is not being offered the same opportunities for treatment simply based on their age, even though we know that the disease itself might be quite similar in any given scenario. But with this background information, we can increase those opportunities, and then also we can use the information that we find from our clinical research to increase our clinical trial opportunities for patients as well. So a patient who is having melanoma come back and they've exhausted all standard of care treatments, we want to be able to look for treatment clinical trial opportunities for that patient, just as we would for an older adult patient. So what does the future hold for us? Well, we need research and we need collaboration to improve the recognition of pediatric melanoma, to improve the diagnosis, to improve our ability to prognosticate or predict who's going to have a good or bad outcome, to improve our understanding of the disease from all aspects, to expand our treatment options for patients, and this is all truly to improve patient outcomes. So with that, I'll leave you with a little bit of information about our center. In Pittsburgh, we have a pediatric melanoma program. We function between our children's hospital and our adult hospital, which houses our main melanoma program. We're always willing to see any patient that might need cared for after a diagnosis of any type of melanocytic tumor that a provider is not sure what to do with. We're always happy to talk to doctors and other care providers about patients if they're feeling stuck, even if the patient is unable or maybe not necessary to come and see us for an actual appointment. But our door and emails and minds are always open to care for any patients. Our information is here, including our wonderful administrative coordinator, Lauren, who fields phone calls and emails from worried parents and patients and care providers all over the country. And with that, I will thank you.